We are on the record at 4:01 p.m. on November 14th, 2022. This is the Zoom recording of Dr. Alexander Peralta. The court reporter is Bonnie Smith. Will counsel please introduce themselves and state an objection to the witness being sworn in remotely?
James Potts, I'm here on behalf of Ms. Couch. We have no objection.
Sharonda, I can't hear you.
Anyone else? I can't.
Sorry. Sharonda Barnes on behalf of Dr. Shiver, no objection.
Felicia.
Hey there. Oops, sorry, go ahead.
Go ahead.
This is Taylor Revenue on behalf of Carol Renee Bonner, no objections.
This is Felicia LeRae on behalf of the Homestead Hospice and Creative Care Hospice entities. No objections.
Okay, Dr. Peralta, would you raise your right hand?
I'm sorry, introduce myself? Yes.
No, just raise your right hand.
Oh, yes, ma'am.
Do you swear the testimony you're about to give in this call to be the truth, the whole truth, and nothing but the truth?
Yes.
Thank you.
You state and spell your full name, please.
Alexander Peralta, Jr., MD.
And where do you work?
I own my own company. It's called Palliative Medicine Consulting Services.
Yes, sir. Do you still practice medicine?
Yes, sir, I do.
And where do you practice medicine?
In the Dallas-Fort Worth Metroplex.
What's the address for your company?
I'm sorry, the address of my company is 802 Kensington Drive, Duncanville, Texas, 75137.
All right. And you've given depositions before?
Yes, I'm giving a deposition, yes.
You've given depositions before.
I didn't understand.
Hey, Bonnie, I don't know if someone else doesn't have their computer muted. I'm not sure who it is, but they can mute that computer. Felicia, Sharonda, Miss Revenue.
Okay, I can hear you now.
Yes, sir.
No, what was your question?
Have you given depositions before?
Yes,
And you're aware this is a public document
yes,
and your opinions will be public knowledge?
yes,
They may be uploaded to YouTube.
yes,
They may be shared publicly online.
yes,
And your deposition and your opinions may be shared with your specialty boards.
yes,
Hospice and Palliative Care Board.
yes,
Also your Internal Medicine Board,
yes,
as well as with your colleagues,
yes,
professional colleagues,
yes,
department heads,
yes,
residents or fellows you may teach,
yes,
by other lawyers, both sides,
yes,
so that they can use that information to make decisions going forward about your credibility and your usefulness in future cases.
yes, sir.
You provided a CV.
Yes,
Are there any articles in your CV that deal with a hospice employee that was convicted of elder abuse of a patient?
no,
All right. Do you have any experience regarding hospice employees convicted of elder abuse of a patient?
no,
Zero experience with that aspect of this case?
let me rephrase that, okay?
Sure.
Okay, I've done hospice and palliative care. I've done hospice for 37 years, and I've done palliative care since 2005. I have been involved in such family situations where there is abuse and neglect, but never in a court proceedings.
Yes, sir. Objection, move to strike as non-responsive. I'd like to ask you my question. Do you have any experience with a hospice employee convicted of elder abuse of a hospice patient?
No,
All right. Do you have any experience of a hospice employee convicted of attempted murder of a hospice patient?
no,
Anything in your CV regarding a hospice employee who was convicted of attempted murder of a patient, a hospice patient?
No,
Zero experience with that aspect of this case, right?
yes,
Have you ever employed an office manager who'd been arrested 36 times?
no,
All right. Would you employ an office manager that had been arrested 36 times?
no,
All right. And you're aware of the office manager in this case had 36 arrests?
yes,
All right. Have you ever employed physicians who lied under oath?
no,
Have you ever employed a physician who lied under oath about his medical qualifications?
That answer could be yes, because I have been an expert witness in an OIG case.
Yes, sir. But you didn't employ a physician that lied about his credentials.
No,
Would you employ a physician who lied to you about his credentials?
no,
Would you, if you realized an employee who claimed he was board certified was not board certified, would you terminate that physician's employment?
Object to form.
You may answer.
Join.
Was your answer yes?
yes,
Have you ever lied about your board certifications?
no,
You agree that that would also be unethical for a physician to lie about his board certifications?
Yeah.
Object to form.
You may answer.
Join.
Do you understand the question? Would you like it read back?
repeat the question.
Sure. Bonnie, do you mind reading that back, please?
Question, you agree that that would also be unethical for a physician to lie about his board certifications? Answer, yes.
Yes. And you're also aware that a physician can lose his license for conviction of a felony?
Yes,
And you agree that lying under oath in a courtroom is a felony?
yes,
Object to form.
Join.
You may answer.
yes,
And so if a physician was being asked questions by a prosecuting attorney and he lied to that prosecuting attorney, told that attorney that he was board certified when he was not, that is something a physician can lose his license over.
Object to form.
Join calls for a legal conclusion.
You may answer.
it depends on the board.
Yes, sir. Well, I didn't say what the board would or would not do. That's something that under board rules in every state in this country, that physician could lose his license over.
Object to form.
I don't-
Join calls for a legal conclusion.
You may answer.
I don't know.
Well, it'd be an ethical violation.
No comment.
Object to form.
Join.
Answer. It would be an ethical violation.
Object to form.
Join.
You may answer.
What was the question again?
That would be an ethical violation.
Object to form.
Join.
Violation, repeat the whole question.
Bonnie, do you mind reading that back, please?
Question, yes, sir. Well, I didn't say what the board would or would not do. That's something that under board rules in every state in this country, that physician could lose his license over.
So what is the question?
That is the question.
I'm reasserting my objection.
Join.
I'd like to make a comment.
You may answer the question.
Yes,
All right. Now, there's nothing in your CV, no articles or references to anything remotely akin to administering fentanyl and morphine and Valium and hydrocodone and diazepam and Ativan to a patient by a non-medical and non-nursing employee with no education or training on administering those drugs.
that's a long-winded question. So the answer is I am an expert in pain management,
Yes, sir.
okay? And I'm an expert in pain and symptom management. And I have written articles on all those drugs that you mentioned.
Yes, sir. And you answered that question. You didn't answer my question. Bonnie, would you read back my question, please, ma'am?
Question, all right. No, there's nothing in your CV or references to anything remotely akin to administering fentanyl and morphine and Valium and hydrocodone and diazepam and Ativan to a patient by a non-medical and non-nursing employee with no education or training or on administering those drugs.
That's a very specific question. And I've trained people. So most of the people I've trained have expertise. And most hospice people have expertise in pain and symptom management, including the drugs you mentioned.
Objection moved to strike as non-responsive. There are no articles in your CV that deal with administering fentanyl and morphine and Valium and hydrocodone and diazepam and Ativan to an 81-year-old patient.
Object to form.
You may answer.
Join.
No,
All right. And so, of course, there's nothing in there in your CV regarding administering those drugs to a patient that a physician had never seen before.
yes, there is.
All right. What is that?
It's an article that I wrote for Dan Miller on end-of-life care.
All right. Anything else?
I've written an article on non-pain symptom management, on Texas medicine, on the administration of the drugs you mentioned for non-pain symptom management.
All right. Anything else?
I could give you a litany of all the people that I've trained under, but you wouldn't know who they are. But they're experts, world experts in pain and symptom management worldwide, including the person who developed the Agency on Healthcare Policy for Cancer and Non-Malignant Pain, which is Richard Payne.
Have you prescribed 600 milligrams per day of morphine or morphine equivalents to a patient that's not opioid tolerant?
Object to form.
You may answer.
Yes,
All right. And when was the last time you prescribed 600 milligrams of morphine to an opioid naive patient?
you keep moving back and forth, so I can't understand you. What was the question?
Your question, please, Bonnie.
Question, all right. And when was the last time you prescribed 600 milligrams of morphine to an opioid naive patient?
4 days ago.
All right. And 600 milligrams to be taken by that patient in a single day.
Yes,
Was there also fentanyl?
yes. And just to elaborate, you have to calculate the morphine equivalents when somebody comes to see you. And I do that all the time. And I've given patients over 2,000 to 3,000 milligrams of morphine or morphine equivalents due to their pain and non-pain symptom management.
Per day?
Beg your pardon?
Per day?
Per day, yes, absolutely.
These are patients you've never seen before?
Yes,
Okay. And you're having these medications, these drugs administered by a non-healthcare provider, not a nurse and not a physician.
that is the standard of care for hospice.
Sir, you
Administered-
listen carefully to my question, answer my question.
Yes.
and Talk, okay.
Dr. Peralta, you can expound upon your answer any way that you feel like you need to, okay?
Okay.
And did you also prescribe benzodiazepines to that patient? I can't hear you. You said yes?
Yes, that's correct.
What benzodiazepines did you prescribe to those patients?
Mostly lorazepam, which is usually part of the drugs that we use for symptom management, anxiety and agitation.
Yes, sir. What else did you prescribe?
For what?
Anything.
Well, I prescribed a variety of different drugs.
So you prescribe the fentanyl, you prescribe morphine, you said 2,000 to 3,000 milligrams per day, and also benzodiazepine, lorazepam, is that right?
Well, lorazepam is a benzodiazepine, so is Valium, a benzodiazepine. Clonazepam is a benzodiazepine. All of these drugs are used for part of pain and symptom management.
All right. And did these patients die?
No,
Patients still alive?
yes, well, if they survive their terminal diagnosis.
Yes, sir. Is that in a hospital setting?
No, it's a hospice and palliative care setting,
And
usually a home setting.
at home? Have you employed a medical director who was not board certified?
Yes, I have.
All right. When was that?
You're testing my memory, but it was probably in 1994 or 95.
All right. Have you employed a medical director who was not board certified since 1994, 1995?
Object to form.
You can answer.
I don't remember.
You don't remember employing one since 1994, 1995?
Well, I would say yes, I have, just to answer your question.
Well, when was the first board certification by the hospice and palliative care specialty?
My board certification,
Sir?
my nice
No, when was the first certification?
for me. Well, I have
No, for the specialty board.
Okay, all right, so just a minute and I'll tell you, because I did send that to Ms. Barnes, the pictures. And I don't have that in front of me.
I think he's asking when the board offered it, not for you in particular.
Well, okay, the board certification, I'll have to look at my diploma. I took the board certification a year after it became a subspecialty. And the reason that I took it a year after is because I was selected by the board to write questions for the first board exam on hospice and palliative medicine. So if I can look at my phone and look at my picture, I can tell you what year. Okay. I was initially certified by the American Board of Hospice and Palliative Medicine on 1998, January 1, 1998, and then I was recertified in December 31st, 2013.
And that was the first year the certification was offered.
That was the second year certification was offered.
So the first year was 1997.
Okay, that's correct.
And of course, 1994 came before 1997.
You asked me somebody was certified was board certified. You didn't say what kind of board. I've
Yes,
hired doctors who were not boarded in internal medicine as my medical director, to be specific.
What did you say?
You asked if I have ever hired someone that was not board certified. You didn't say what specialty board. I have hired doctors, medical directors that are non-board certified in internal medicine or any other type of board certification.
And you did that in what year?
That's what I told you, 1994.
Right, and 1994 came before 1998.
You're not understanding the question.
Yes, sir, I do understand you. You listen to my
There was
question.
no board on 1994.
1994 came before 1998. That's my question. I'd like an answer.
Of course.
All right. So the Hospice and Palliative Care Board was not available until 4 years after you employed a non-board certified medical director.
Okay. Now, once again, you're saying non-board certified.
I'd like an answer to my question.
Repeat your question.
Would you read it back, please, Bonnie?
Question, all right, so the Hospice and Palliative Care Board was not available until 4 years after you employed a non-board certified medical director.
Yes.
Now, these patients that you prescribed 2,000 and 3,000 milligrams of morphine plus fentanyl plus benzodiazepines, plural, were they suffering from cancer?
Yes.
And they suffered from intractable pain?
Yes.
You're aware that Ms. Couch did not suffer from cancer?
She had non-malignant pain.
Can you hear me all right?
Yes. I know she did not have cancer.
She did not have cancer. She did not have intractable pain.
False.
All right. I'm going to show you what's been marked as Exhibit 1 to your deposition.
She had intractable pain according to the chart.
I'll start with, you of course feel like she was hospice appropriate?
Absolutely.
You recall reviewing Dr. Singh's statement?
I'm sorry?
Do you recall reviewing Dr. Singh's statement?
The affidavit?
Her statement?
No, I don't recall.
Let's talk about what you may have reviewed. Did you review the Homestead Hospice medical records for Shirley Couch?
Yes,
Did
Thoroughly.
you review the Athens Regional Medical records?
yes.
And did you review the depositions?
Whose deposition?
I want to know what depositions you reviewed.
I reviewed Dr. Shriver's deposition,
Dr. Who?
Dr. Shiver's deposition.
All right. What other depositions did you review?
That's the only one,
That's the only deposition you reviewed?
correct.
You did not review the admission nurse's deposition?
No, but I reviewed her notes.
You did not review Mary Pippin's deposition?
No,
You did not review Rachel McKnight's deposition?
no,
You did not review Mary Pippin's deposition?
no,
You did not review Christy Fowler's deposition?
no,
You did not review Tracy Sorrow's deposition?
no,
You did not review Ashley Mercer's deposition?
no,
You did not review Julie Rust's deposition?
no,
You did not review Kelly Stansel's deposition?
no,
You did not review Ashley Metz's deposition?
no,
You did not review Mary Allen's deposition?
no,
You didn't review any depositions in this case other than Dr. Shiver's deposition?
that's correct.
You did not review the Athens Regional Medical Center records?
I did.
All right. You did not review the trial transcripts in this case?
I didn't understand your question.
You did not review the trial transcripts in this case?
Yes, I did.
You reviewed the trial transcripts? Yes?
Yes,
You reviewed the GBI investigation?
yes,
You reviewed Ms. Bonner's statement?
yes,
You reviewed the coroner report?
yes,
Then you recall Dr. Singh's statement?
no. Oh, okay, wait a minute. Was that the doctor and the facility?
Do you recall it or you do not?
Yes, I recall it.
All right.
I said yes.
I heard you. You recall that Dr. Singh said that Ms. Couch was not hospice appropriate?
Yes,
And of course, she cared for her.
repeat the question.
Dr. Singh cared for Ms. Couch.
That is correct.
Dr. Singh was her physician.
No, Dr. Park was her physician.
At Athens Regional Medical Center, you're saying that Dr. Park was her physician?
Well, you didn't say that. You asked me that question. Dr. Singh is the doctor in the hospital center.
That's
He
right.
was a hospitalist in the doc. It's not her doctor. He was a doctor, attending doctor at the hospital. Make that clear.
Dr. Singh cared for Shirley.
Hold on,
Couch.
Dr. Peralta, were you done with your answer?
I'm done with my answer.
Okay.
Dr. Singh cared for Ms. Couch.
During her hospitalization and admission to the ED.
That's right. She was Ms. Couch's physician.
During her hospitalization.
And Ms. Couch was her patient.
That is correct.
After she left Homestead Hospice and the care of Dr. Shiver.
Objective form.
You may answer.
What's your question? You made a statement, not a
Can
question.
you read it back, please?
Question, after she left Homestead Hospice and the care of Dr. Shiver?
Yes,
And she said that Shirley Couch was not hospice appropriate.
he's not a hospice expert. He's a
That's not
hospital.
my question. Can you hear me all right?
I can hear you, and she's wrong.
Like an answer to my question.
I disagree, but yes, that's what you said.
All right. And you disagree with her.
Absolutely.
And you think that Shirley Couch could have been given 2, perhaps 3,000 milligrams of morphine per day, and that would have been within the standard of care.
Depending on her pain rating, yes.
All right. And in addition to 2,000 or 3,000 milligrams of morphine or morphine equivalent, she also could have been administered benzodiazepines, multiple benzodiazepines. That too would have been
Yes.
the standard of care.
Yes,
And that's even though she didn't have cancer.
he had non-malignant pain.
Non-malignant means. Is that right? I think that somebody else had the mute off.
So non-malignant pain, for your information, is well documented in the Agency of Healthcare Policy and Research written by Dr. Richard Payne. And non-malignant pain can be worse than cancer pain in the literature.
Yes, sir. You never spoke to Ms. Couch.
I'm sorry?
You've never spoken to Ms. Couch.
No,
You've never examined her,
no,
never asked her about her pain.
no.
All right. You're familiar with Randall Basalt?
I didn't understand you.
Are you familiar with Randall Basalt? B-A-S-E-L-T.
No,
Familiar with a treatise entitled Disposition of Toxic Drugs and Chemicals in Man? Never heard of that?
no,
What about O'Donnell's drug injury?
no,
You've heard of the PDR, the physician's desk reference, right?
absolutely.
And that is a compendium of package inserts for drugs
That is correct.
put out by drug manufacturers
That is correct.
to enable physicians to safely use those drugs, right?
Correct.
And do you know what a black box is?
Absolutely.
What is a black box?
Black box states not to use that particular drug unless it's the discretion of the physician and for the healthcare of the patient. Does not limit the physician from prescribing a drug.
Yeah, black box warning is for the safety of the patient, right?
Correct.
You agree as a physician, the patient safety is of paramount importance?
Absolutely.
And you testified earlier that for an opioid naive patient, it would be within the standard of care to prescribe 2,000 to 3,000 milligrams of morphine or morphine equivalent and multiple benzodiazepines.
Yes,
And in your view, that's not violative of any black box for Duralgesic or fentanyl?
no. That's well documented in the palliative care, Oxford textbook of palliative medicine, which is the experts in hospice and palliative care,
Mhm.
not the PDR. The PDR is not an academic textbook of medicine.
What's in the PDR has to comply with federal law. Does it not?
No, it doesn't.
Actually, okay, cite for me any textbook, treatise, grand rounds, throwaways, anything in the history of the solar system that says the drug manufacturers, package inserts do not have to comply with federal law.
Objection form calls for a legal conclusion.
You may answer.
They do.
They do what?
The compendium of medications. So they do have to comply with federal law
So why did you just testify under oath they did not?
because it's not a medical.
Form.
You may answer.
It provides information about drugs, period.
Why did you just testify it didn't have to comply with the law?
I meant didn't have to comply with medical standards of practice. I stand corrected. Does have to comply with the law, but not with standards of medical practice.
The trial transcript that you read in this case, you read Dr. Park's testimony?
Yes,
Dr. Parks was asked at page 103, well, then let me ask for a little background on Ms. Couch. Did she have a history of opioid use or abuse? His answer was no. You agree with that?
yes, that's correct.
And was she opiate resistant is the word he used? His answer was no. You agree with that?
Yes, she was allergic to codeine.
She what?
Yes, she was allergic to codeine.
Yeah, but what that means is she was an opioid naive patient.
At that point, yes, when he referred her, yes.
And he was asked about the medications. You recall reading that in the trial transcript?
Yes,
And he was asked what sort of medication might be used for someone who has an opioid resistance. And the prosecutor, I think, well, you and I know, he meant for an opioid naive patient or someone who wasn't opioid tolerant, right?
Objection to form that it mischaracterizes earlier testimony.
You may answer.
there's a difference between opioid resistance and opioid naive. So what are you asking me? Do you know the difference?
Opioid resistance, opioid resistance is not the proper phrase. Is it your testimony that it is?
The opioid resistant is not an appropriate phrase. It's opioid naive. And she was not opioid naive. She was given tramadol and hydrocodone on the 6th of January before she got morphine. So she was not opioid naive.
So she had built up a tolerance to opioids, having tramadol in January of that year.
I said June. June the 16th. That is in the
June
record.
16th. Okay.
You're
So-
misinformed.
The 1st of June, she was opioid naive.
Well, that's right, but that's not when she got morphine.
Okay. But when she was admitted to hospice, Shirley Couch was an opioid naive patient.
That is correct.
All right.
That's the only correct
Good.
thing you said.
I'm sorry.
Nothing, that's correct.
At page 104, Dr. Park was asked, but Ms. Couch at 81 years old didn't have any of that sort of history. No. Based on your knowledge of Ms. Couch's history, would you have prescribed a 50 microgram fentanyl patch? His answer was no. Question why? That dose would be too high for someone who had not taken pain medication previously. Do you remember reading that?
Yes,
And you disagree with Dr. Park?
yes, because she was not taking those drugs at that time. They were titrated.
Yeah, and you disagree with Dr. Park like you disagree with Dr. Singh, right?
Correct.
All right. And if you start an opioid naive patient at a 50 microgram Duragesic patch,
Never.
right? And that's because there's a black box warning against that in the PDR.
There's no
Right.
black box book warning on fentanyl patch for that. For starting at a certain dose.
Are you saying there's no black box warning?
For starting someone at that dose, there's a black box warning, but not at that dose.
It doesn't have the specific dose in the black box. Is that what you're
Well,
saying?
what is it?
Yeah. What are you talking about? What is it?
Well, I'm asking you, you're saying there's a warning. What is the warning?
I'm reading it. This is immediately beneath the black box. Yes, there is a black box warning for fentanyl. Are you aware there's a black box warning?
Yes, there is.
And the black box warning deals with fentanyl and morphine and other opioids? You aware of that?
Yes, I am.
Okay. And that warning says you don't combine those two drugs because of the dangers to the patient.
Object to the form.
You may answer.
Join.
No, it's not, doesn't hurt the patient.
So morphine and fentanyl does not hurt the patient, combining the drugs.
It's part of the standard of care of pain management.
Uh-huh.
I have patients on morphine, I have patients on hydromorphone, and I have patients on fentanyl.
And these are cancer patients?
No, these are non-malignant patients, non-malignant pain patients.
What's the dose that you have them on?
Oh.
2,
Ms. Barnes, I
3,000?
need to answer that, but that's private information on my patient.
Okay. But it would have been appropriate to give Shirley Couch 2,000 to 3,000 milligrams of morphine or morphine equivalents per day.
Well, that's an erroneous statement. She didn't get 2,000 or 3,000 milligrams.
So, but that, you testified that would have been within the standard of care in this case.
If she was receiving that, but she was not receiving that. She was
Sir?
about 300.
So read back my question, please, Bonnie.
Question, you testified that that would have been within the standard of care in this case.
Yes,
And for the record, that's the last time I'm going to allow him to answer that question that's been asked now, at least 4 times.
You have to answer whenever you like.
Okay. I'm just letting you know.
Yeah, and of course, Bonnie will be taking that down. Adult dosage is only for severe pain, fentanyl, right?
no, it's also for children.
I said an adult dosage is only for severe pain.
Yes.
All right. And it requires
There is a
around,
caveat to that. Okay,
and it requires around the clock management.
what do you mean?
Object to the form.
Join.
Sure.
There's no medical person that looks to be with a person that is on a fentanyl patch. It's
What
like
if-
any other medication you get. You monitor for symptoms, and hospice monitored for her symptoms.
it requires around-the-clock management.
No,
All right, so you disagree with the federally mandated what's in the PDR?
within my realm of expertise, yes.
Okay. And you agree that
Ms. Barnes, could I make a comment?
sure, go ahead. What's your comment?
You could just answer his questions.
This is regarding fentanyl, okay? I was involved in a worldwide study by Janssen Pharmaceutical.
I'm not, that's not responsive to my question. Objection, move to strike is non-responsive.
I was making a comment. I'm an expert in fentanyl.
You're an expert in fentanyl, you testified,
Correct.
sir?
Yes,
And you did work for the manufacturer?
did I, what?
You did work for the manufacturer.
Yes, I was
were-
an expert for Janssen Pharmaceutical,
Yes, sir. You did,
pain management.
sir. My question is about developing, did you develop the drug?
No, but I developed a safety study for children,
All right.
fentanyl patch.
You realize Shirley Couch is not a child.
I understand.
Okay, she's 81 years old.
Correct.
All right.
And children get a 50 microgram patch of fentanyl also.
Yes, sir. What do you want to talk about children today?
No, I'm just telling you that it's not just for adults.
Yes, sir. I never said it was just for adults. We were talking about an adult dosage. I'm not here to ask you about children because the case has nothing to do with children. Do you understand that?
Yes, yes, that's to do with expertise in fentanyl.
Well, that's a small portion of the case. You understand that?
That's a big portion of the case.
Is it? You agree a family practice physician is not the same as a hospice physician?
Disagree.
They're the same to you?
Yes,
All right. You understand that, have you ever been sued?
no,
Have you ever been interviewed by a federal government agent regarding a Ketam matter?
no,
You agree Shirley Couch was not suffering from pressure ulcers?
I didn't understand your question.
Could you read it back, please, Madam Court Reporter?
Question, you agree Shirley Couch was not suffering from pressure ulcers?
That was noted on the chart that she had pressure ulcers.
Where was it noted in the chart?
In the admission, the plan of care, when the nurse admitted her, Ms. Knight. You want me to give you a page number?
No, I've got it. It's not the plan of care, though. And try again.
Okay. In the plan of care and also in the local coverage determinants.
All right.
So the local coverage determinants that showed she was eligible for hospice care.
Yes, sir. And it says she was eligible for a hospice care because she had pressure ulcers.
No, she was eligible for hospice for a variety of different reasons, comorbidities, ambulation, incontinence, transfer, dressing. She had problems with decline in her clinical status. And she had multiple symptoms, and she also was given a score of 40 on the PPS scale, which is appropriate for hospice. She had pneumonia and sepsis and pyelonephritis, progressive malnutrition, weight loss. So she was very well appropriate for hospice care, increasing dyspnea, respiratory rate, cough, nausea, diarrhea, and increasing pain.
Anything else?
Met all of the requirements for the local coverage determinants as determined by Palmetto GBA, which is the fiscal intermediary for that hospice.
Mhm. You agree, Dr. Shiver was not board certified in hospice and palliative care?
Yes,
He was not board certified in geriatric medicine?
Yes,
He was not board certified in bariatric medicine?
yes,
He was not board certified in adult medicine?
yes,
He was not board certified in emergency medicine?
yes,
He was not board certified in family medicine?
yes,
He was not board certified in internal medicine?
yes,
He had no board certifications at all?
correct.
You recall that he lied at his deposition about his board certifications?
Object to form.
You may answer.
Yes. He got confused.
Have you spoken with him?
No, I just heard his deposition.
He lied under oath in his deposition.
Object to form.
You may answer.
Is that a question? Are you asking him to make a legal determination if he lied under oath?
You may answer. If you make another speaking objection, Sharonda, we're going to let the
You can do what you like. I'm just asking you to ask questions of my witness and not make
well,
statements.
I am asking questions.
Well,
Go ahead.
It wasn't a question.
Speaking objections. You may answer.
repeat the question.
Would you read it back, please, Bonnie?
Question, he lied under oath in his deposition?
Yes,
Same objection.
And he also lied under oath at trial.
Same objection.
You may answer.
I don't know.
Well, did you read his trial transcript?
No,
Well, you testified earlier, you did read the trial transcript in this case. Which is it?
all right, so I guess yes, I guess the answer is yes. Because
All right.
I got his deposition, but I also read his trial transcript. You're correct.
Right. In his deposition, he admitted that what he said at trial was false when he said it.
Yes.
Object to form, misstates testimony.
You may answer.
Yes,
You're aware that Shiver has no publications regarding hospice or palliative care?
I don't know.
Are you aware of any?
No,
Not aware of any regarding geriatric medicine,
no,
the use of opioids,
no,
the use of fentanyl,
no,
the use of benzodiazepines?
No.
The use of fentanyl, morphine, hydrocodone, and benzodiazepines in a hospice or palliative care setting?
the answer is no. I don't know if he's done any publications in that area.
You know that Dr. Shiver was moonlighting.
No.
You read his deposition?
Okay. Well, what do you mean by moonlighting?
If you read his deposition, that's a word he used, moonlighting. Do you remember that or not?
Oh, he worked for another hospice or program. Yes.
Yes, it was moonlighting. He said he was moonlighting.
Object to form.
If he said it was moonlighting, then he was moonlighting. I don't know what that is.
Because he had a full-time job at Athens Family Practice. You remember that?
Yes, he did.
And between he and another patient, another physician, he had what, 3,000 patients?
I imagine so. That's true if he said that.
Yes, sir. And that was across town.
I don't know the location.
All right. And he was on call 24/7.
As most doctors are, yes.
Most doctors on call 24/7, 365 days a year without any cross coverage.
Yes, that can happen.
I didn't say whether it can happen. You said most doctors are. I mean, this
No,
is, and we'll see what your board thinks about it. Go ahead and tell me. Your testimony under oath is that most doctors have no cross coverage and they cover 24/7, 365, right?
I was speaking for myself. No, the answer is no. Most doctors have coverage.
That's right. That's just the opposite of what you just testified to.
Okay. well,
Object to form.
You confused me. Okay. So
Okay.
the answer is no. Okay?
That's right. And most doctors have coverage, right?
Most of them do.
Right, because it's impossible. It's humanly impossible to work 24/7, 365, right?
I disagree. I have done that before.
Okay, well, and you feel like you can
In
give,
most doctors,
don't
but-
interrupt me again. You can give appropriate care 365 days a year, 24 hours a day, 7 days a week.
absolutely.
And cite for me any publication, and I want any treatise, textbook, chapter in a textbook, peer-reviewed publication, non-peer-reviewed publication, any article that you're aware of at all that says most physicians work without coverage, and that is just as safe as having coverage. Cite for me any publication.
Object to form.
You may answer.
No, I don't know of any publication.
Mhm. You're also aware that Dr. Shiver did not have admitting privileges.
Uh, to what? Hospital or what?
Well, where do you have admitting privileges other than a hospital?
Nursing home and other facilities? Be specific. Admitting privileges to what? Hospital?
You're saying that you have admitting privileges for an ambulatory care center? Is that
Yes.
your testimony?
That is correct. If I'm needed for have a person in a nursing home, I need to have admitting privileges to that nursing home. To a hospital, it's very different.
Right. You're
Hospital,
aware that
be
Dr.
specific.
Shiver, don't interrupt me. You're aware that Dr. Shiver didn't have admitting privileges anywhere. Is that right?
Object to form, misstates testimony and is factually.
Yes,
Okay. And are you also aware that a medical director is required under Georgia law to have admitting privileges? And a
Objection.
hospital commonly, don't interrupt me. The medical director is required by law to have admission privileges at one or more hospitals commonly serving patients in the hospice's geographical area. Are you aware of that?
Object to form.
because I don't practice in Georgia.
All right. Have you ever practiced in Georgia?
No,
All right. Have you ever been to Georgia?
yes,
Have you ever been the subject of a False Claims Act investigation?
No,
Did you write a paper regarding a False Claims Act investigation?
no.
Mr. Potts, can we stop for a minute? I believe Ms. Larray is having an issue with her sound.
Oh, sure. You want to take, how much time? You want to take a 10-minute break, doctor?
That'll be fine.
Sir? Well, I couldn't understand you.
Yes,
Yes, all right. 10 minutes then?
That's good. We're back on the record at 5:21 PM.
I'm looking at the local coverage determination document. Do you have that?
yes, sir.
All right. Make that, is that part of your medical record? Make that
Yes, sir.
exhibit under your deposition.
Yes,
And if you're looking at, it's page 1 of 3, do you see that? It's 3 pages total.
yes, there are 3 pages, correct.
That's the up in the top right, page 1 of 3, 2 of 3, 3 of 3. Is that right?
All right, that's 3 pages.
Page 1, patient name Shirley Couch.
Correct.
Certification period 6/1/2017. That's the 1st of June to 8/29/2017.
That's correct. That's the first benefit period.
Yeah, that was her benefit period, but of course she left on the 26th of June, right?
She was discharged on the 26th of June.
Right. And the medical director was James Shiver, MD,
Correct.
and he was also her physician.
He was her physician under hospice. Yes, correct.
He was also the medical director.
Correct.
And it's your testimony that it's common to have the medical director also be the only treating physician in a hospice setting.
Yes,
And do you see primary LCD in the center at the top?
I'm sorry, just do I see what now?
It reads top center primary LCD. Do you see that?
Yeah, it's a local coverage determinant that I was talking about.
Yes, sir. And it reads general decline in clinical status. Is that right?
That is correct.
And that's what the primary LCD is in this case, in Shirley Couch's case.
Correct. Well, she did have heart disease and she did have cerebrovascular disease.
If you move down to, you see where it reads item A,
Mhm.
psychological impairment of functional status as demonstrated by what?
Yes.
I mean, there's nothing for item A. Is that, do you see beneath that current PPS 40%?
Correct. That is functional status. That is the tool we use. We use the Karnofsky scale, and then we use the palliative functional status. That's the status of the patient. And she was at 40%.
Do you recall that Dr. Shiver did not know what the Konofsky scale was?
So I don't know if he didn't know what it was, but this is the PPS scale.
Yes, sir. You read his deposition, right?
Yes.
He was
He said
asked,
he- Karnofsky scale was, but we're talking about the PPS scale. That's 2 different things.
right, well. Okay.
The Karnofsky scale was developed for cancer patients. The
Right.
PPS scale was developed for non-malignant patients.
And
Are you familiar with the PPS scale?
I am. Are you ready for my next question?
Yes,
You, under item B, ADL stands for what?
activities of daily living.
Right, and it reads ambulation, and there's a check next to. Do you see that?
Yes,
That indicates what?
that she had difficulty in ambulation, difficulty in continence,
Can't walk.
difficulty in transferring. So all of those are activities of daily living.
Yes, sir. Ambulation means walk, right?
Correct. able to
Says-
stand, walk on your own.
This says she cannot walk on her own, right?
That's correct.
That she's incontinent of bladder or bowel or both. Is that right?
I didn't catch your last part.
What is continence? What does that mean?
You know, it means that they're incontinent of bowel and bladder at times,
Bowel,
all the-
bladder, or both, right?
urine and fecal material, yes,
Transfer
correct.
means what?
Transferring from a wheelchair or a bed to a commode,
According to this document, she's also unable to do that, right?
correct,
Unable to dress herself. That's what that dressing means, right?
uh-huh,
Unable to bathe herself,
that is correct,
right? And the comorbidities, do you see that?
correct, yes, sir,
I think when we testified earlier, you read all those. Is that right?
that's correct,
But there's only a check box next to neurological disease. You see that?
that is correct.
Those aren't all checked.
That's the neurological disease because that she had cerebral vascular disease and she had a stroke.
Right, the stroke was 9 years ago.
I'm sorry?
The stroke was 9 years ago.
Correct,
And chronic obstructive pulmonary disease, she does not have that, right? According to this portion of the medical record.
that is correct. She had in the bottom that she put on there that she had dysphagia, she had oral pharyngeal.
Sir, that's not my question. Objection, move to strike.
Okay, well then neurological disease, because that is policy, that's the LCD for this particular patient.
That's right. She
You
does
can
not.
move to strike his answer when he's done giving his answer, but don't interrupt him. Be
You mean-
respectful.
Thank you. You see that?
Yeah, correct, yeah, neurological disease.
Comorbidities, Shirley Couch, and on June 1st, 2017, did not have chronic obstructive pulmonary disease. True?
Just a minute, okay. Let me just pull up my evaluation. No, I don't have her listed as having chronic obstructive pulmonary disease.
Because she didn't have it, right?
Correct, no,
She did not have congestive heart failure.
that is correct.
She did not have ischemic heart disease.
I do have it in my notes, but I'll grant you that it's not marked here.
All right. Did not have diabetes. Mellitus.
That's correct,
She did not have renal failure.
that is correct,
Did not have liver disease.
Correct.
Did not have dementia.
correct,
Did not have acquired immune deficiency syndrome.
Correct.
HIV. Did not, right?
correct, uh-huh,
Did not have refractory severe autoimmune disease, e.g. lupus or rheumatoid arthritis.
that is correct.
Current UC 6/4/2017. This is what you wanted to read a moment ago, right?
Correct. The dysphagia, hypertension, deep vein thrombosis, carotid artery disease, osteoarthritis, and hemiplegia from the stroke.
Dysphagia is what?
Hemiplegia, which is,
No, dysphagia.
no, I said hemiplegia.
Are you testifying that she had hemiplegia?
Yeah, she had a right ischemic stroke, a hemorrhagic stroke with the left hemiparesis.
Talk about, well, first I'm reading here what you were reading earlier, and it reads, my version reads 6/4/2017, dysphagia. Doesn't say hemiplegia.
Right.
Right, and dysphagia is what?
It's difficulty in swallowing.
Yes, sir. Have you ever had difficulty swallowing?
I'm sorry?
Have you ever had difficulty swallowing?
Yes, after COVID.
Yes, sir. That doesn't make you hospice appropriate, right?
I was almost hospice appropriate because I almost died from COVID.
But dysphagia does not make you hospice appropriate.
It
Right.
can't, you're aspirated.
Sir?
It can if you're aspirating and you
I
got
didn't say-
aspirated pneumonia.
Okay. Well,
You're making a general statement without any medical knowledge.
no, sir, that's not what I'm doing.
Okay, well.
Dysphagia, you agree
You read
dysphagia
the thing.
alone does not make you hospice appropriate.
No, it does not.
All
It's
right.
one of the comorbidities.
Hypertension alone does not make you hospice appropriate.
I'm sorry?
Hypertension alone does not make you hospice appropriate.
Yes, it does.
Hypertension alone.
Yes. Malignant hypertension.
Go ahead and cite for me a source for that.
It falls under neurological diseases.
So anyone with hypertension is hospice appropriate.
They can be, yes, sir.
Hypertension alone does not make you hospice appropriate.
You're correct.
Well, why did, I mean, I asked you that question a moment ago and you didn't answer it that way. Why is
You
that?
didn't qualify it. Malignant hypertension does. And that's a form of high blood pressure.
Yeah, hypertension alone does not make a patient hospice appropriate.
Correct.
Deep vein thrombosis alone does not make a patient hospice appropriate.
Yes, it can.
I didn't ask you whether it can. I said deep
Yes.
vein thrombosis alone does not make a patient hospice appropriate.
Yes, it does.
It does. Deep vein thrombosis alone makes a
Yes.
patient hospice. So anybody with deep vein thrombosis is hospice appropriate, right?
Yes, because deep vein thrombosis is a prelude to cancer.
The deep vein thrombosis is always a prelude to cancer. Is that your testimony?
That is correct.
All
And
right.
so is pulmonary embolism.
And cite me any,
Well written in the literature of the cancer and
just cite me
textbook of internal medicine.
textbook, a treatise, anything.
Yeah, right. Harrison textbook of internal medicine.
Yeah.
Look it up.
All right. Carotid artery disease alone does not make you hospice appropriate.
It does.
Okay. So someone with carotid artery disease alone is hospice appropriate.
Correct.
All right. Severity of the disease does not matter.
Yes, it does.
Well, so some people with carotid artery disease are hospice appropriate and some people are not.
Correct, depending on the extent of the carotid artery stenosis they have, predisposing to strokes.
So carotid artery disease alone without a severe case does not make a patient hospice appropriate, right?
That is correct.
Same for deep vein thrombosis.
Same thing, yes.
Same for osteoarthritis.
Correct.
Same for hemiplegia.
Yeah.
So
You're correct.
now there's a difference in hemiplegia and hemiparesis, right?
That is correct.
And hemiplegia means this patient is has a left side paresis, paralysis and or numbness.
Can I educate you?
You may answer my question.
Hemiplegia is a weakness. Hemiparesis is a paralysis.
And you cite me any textbook.
Harrison textbook of internal medicine.
Okay.
And
Your
the
testimony is that,
textbook of palliative medicine, both of those books.
that hemiplegia is weakness alone. Is that right?
Yeah, weakness,
And hemiparesis is
hemiparesis is paralysis. Hemiparesis.
And can hemiplegia alone, a patient with hemiplegia alone, be hospice appropriate?
No,
Can a patient with hemiparesis alone be hospice appropriate?
yes,
That depends on how ambulatory the patient is.
and how severe the hemiplegia, or hemiparesis is.
Wait, did you say plegia or paresis?
Paresis.
Clinical status. Recurrent or intractable serious infection such as, and it's blank. What is that infection?
That she had urinary tract infections.
Okay. Now UTI.
Correct.
alone,
It's on
is
the,
that-
on the other page. Pneumonia,
UTI,
sepsis, and polynephritis.
UTI alone does not make a patient hospice appropriate.
No.
Now there's a weight loss of at least 10%. That's not applicable here, right,
It is. He had a weight loss of 12 pounds.
sir? So she weighed 120 pounds. Is that your testimony?
But I just noted that I don't know what her weight was, but it's noted on the chart. She had a weight loss of 12 pounds, according to the admission plan of care.
Yeah, and maybe I read this wrong. It says weight loss of at least 10% body weight in the prior 6 months. Do you see that?
Yeah, I understand that.
Yeah, and you're saying that was at least 10% of her body weight?
Well, I don't know how much you weighed.
Well, that's important. You'd have to know that to answer that question, wouldn't you?
Yeah, I just know that she had weight loss of 12 pounds. And that's significant as part of the comorbidity for hospice.
Right, but unless a patient suffers from at least 10% loss of body weight in the prior 6 months, this section of the LCD would not be applicable, right?
Well, these local coverage determinants are measurements that give a lot of leeway to the admitting doctor. It doesn't have to be exactly 10%. It can be history of weight loss. And 12 pounds is a significant amount of weight loss for a person.
We'd here in excess of 10%, right?
Yes.
You don't know what her body weight is, so you don't know whether she lost 10% or not.
Let me look it up. I don't know if I included that in my note or not. Vital signs. No, I didn't include her weight on her vital signs. So she may have not. I'm not sure. I would say no. I'm not sure that she's lost 10% of her body weight.
You see her mid-arm circumference, is that right? 31 centimeters.
Correct.
And is someone with a mid-arm circumference of 31 centimeters hospice appropriate?
Yes.
30 a mid-arm circumference of 31 centimeters alone makes you hospice appropriate?
No. But it's part of the comorbidities and the information that added together allows a person to be admitted to hospice. Not just one single thing.
What? What did you just say?
It's just one parameter that's measured and it's followed by the hospice team.
Right.
So,
But your opinion is you add all these together and she's hospice appropriate, right?
correct.
And you disagree with her treating physician at Athens Regional Medical Center, Dr. Singh, who said she was not hospice appropriate, right?
Not a hospice,
Object to form.
she's
May
not a
I-
hospice expert.
Sure.
Her testimony is inaccurate, but she's not a hospice expert. She's not board certified in hospice and palliative medicine or a hospital medical director certification.
But neither is Dr. Shiver, right?
So she is, it's
Just to
inconsistent.
answer my question, Dr. Shiver's not board certified in hospice or palliative care medicine, is he?
No.
Nor is he board certified as a medical
We're
director.
talking about Dr. Shiver. You asked me about Dr.
He's not board certified at all. Those are my questions.
Okay, well, you didn't ask me. You asked me about Dr. Singh.
Well, and I'm still asking you about, you
Period.
said because Singh is not board certified, she can't tell you whether this woman's hospice appropriate?
Yeah.
Do you remember what her board certification was?
So I know, but you know, that's a whole,
But sir, what is Dr. Singh's board certification?
okay, tell me what a certification on.
Sir, I'm asking you, educate me. What is it?
On Dr. Singh? I have no idea. I've never got any information from her. How can you ask me a question like that?
You said you read the GBI report.
Yeah, but her credentials are not anywhere in the chart.
Is that, so you didn't realize before today that she was board certified?
Objective form.
You're asking me a question or making a statement?
Sir, answer my question.
Repeat the question.
No, sir. Did you not understand the question?
I understood it. But
You don't remember it? You don't remember it?
I remember it.
All
Repeat
right,
the question.
answer it.
I earned the courtesy. Repeat the question.
No, sir. Answer the question. If you remember it, answer it.
What was the question?
Could you read it back, please, Madam Court Reporter?
Question, so you didn't realize before today that she was board certified?
Same objection.
No,
All right. And you don't know what her board certifications were?
no,
Nevertheless, you said she's not qualified to make a determination about whether Shirley Couch was hospice appropriate.
correct.
You testified she wasn't able to do that because she's not board certified.
Objective form.
Yes,
That's what you just testified to. Now, Dr. Shiver wasn't board certified either, was he?
No.
Not board certified in anything,
correct.
not hospice care, not palliative care, not anything. Right?
Correct.
And you're saying, though, that he was eminently capable of making that determination.
Based on his clinical knowledge, yes, fund of knowledge.
Based on his clinical knowledge, based on what clinical knowledge?
I'm caring for patients that are hospice appropriate, working with a hospice,
What was that? What did you say?
working with patients that were on hospice and working with hospice personnel. Dr. Singh did not work with hospice personnel and was not caring for hospice patients. She cared for acutely ill patients in a hospital.
What was you, for Shirley Couch, you've already testified about the 2,000 to 3,000 milligrams of morphine. What's most you would feel would be appropriate without violating the standard of care? In Shirley Couch's case, 5,000, 6,000, how many?
I don't know, depend on her level of pain.
10,000,
No, I don't think so.
8,000,
No.
7,000?
Well, candidly, she was getting 400 milligrams of morphine. So 400
You
milligrams.
already testified that 2,000 or 3,000 would have been appropriate. What I want to know now is how much more than 3,000 would have been appropriate, but within the standard of care
For whom?
for Shirley Couch.
No, it would have been inappropriate.
What would have been inappropriate?
30,000.
For
Because her
what?
analgesic dose of her morphine was only 300.
Yeah, but you said it would not have been below the standard of care to prescribe her 2,000 to 3,000 milligrams of morphine.
If she had severe pain and she required that, that would have been appropriate.
Right. And would it also have been appropriate to prescribe her 4,000 milligrams of morphine if her pain, in your view, warranted it?
Yes,
Would it also have been appropriate to prescribe her 5,000 milligrams of morphine or morphine equivalent if, in your view, her pain warranted it?
yes,
And would it also have been appropriate to prescribe her 6,000 milligrams of morphine or morphine equivalents had her pain warranted it?
that is correct.
And it would have also been appropriate to prescribe her 7,000 milligrams of morphine or morphine equivalents if her pain warranted it.
That is correct.
And it also would have been appropriate to prescribe her 8,000 milligrams of morphine or morphine equivalents in a single day if her pain warranted it.
Yes, that's correct.
And it also would have been appropriate to prescribe her 9,000 milligrams of morphine or morphine equivalents if her pain warranted it.
That's correct, because there's no ceiling dose for morphine.
Okay, 100,000 milligrams?
Yeah, it's pretty high, yes, but there's no ceiling dose.
So 100,000 milligrams would also have been appropriate.
No, it wouldn't be.
10,000 milligrams would have been appropriate.
If
As
it
a single
warranted,
day.
yes.
11,000 milligrams of morphine in a single day.
No.
Okay, so 10,000. Sir?
No,
Okay. Looking back at LCD, which we marked, is this 2, Madam Court Reporter?
That was the first exhibit.
Okay. Do you share? I'm sorry, what was that? I think somebody had the mute on. Yeah, do you see where it reads symptoms? Now, I don't see any, nothing's checked under symptoms for Shirley Couch, is that right? Nothing's indicated as being an LCT determinative.
the symptoms are dyspnea with increasing respiratory rate, cough, that's intractable, nausea, vomiting, responsive to treatment, diarrhea, intractable, pain requiring increasing doses of major analgesics more than briefly.
Yes, sir.
Those
So
were the-
those are all applicable to her in this case. So yes,
Yes,
right. And under signs,
you want me to read them or?
sure. I mean, if what's under there is, I'd like for you to tell me what
Yeah,
under signs is.
decline in systolic blood pressure below 90 or progressive postural hypotension, ascites, venous and arterial and lymphatic obstruction due to local progression of metastatic disease, and edema. So she had and change the level of consciousness. So I guess they meant to say that she had a decline in her blood pressure.
Yes, sir. And under the laboratory,
The laboratory, they had increasing carbon dioxide or decreasing oxygen, or decreasing what's called O2 saturation of oxygen, increasing calcium and creatinine and liver function. And of course, she didn't have any tumor markers. They didn't mark any of these.
do you remember seeing a liver function test in her record?
Yes, and they were normal.
Okay.
So this is just listing, and then they mark what they see.
Well, I don't see anything marked under symptoms or signs or laboratory. You're saying they're all marked. Is that right?
Well, I think she had the symptoms. I don't know about the signs. The symptoms kind of consistent with her history and physical from Dr. Park and the evaluation by the nurse.
All right. And the clinician name that completed this down at the bottom, that's Rachel McKnight. Is that right?
That's correct, sir.
And if we flip on over to page 3,
Yes, sir.
this is where it reads, increasing visits, hospitalization, progression to dependents with ADLs. And this is a ambulation, continence, transfer, dressing, feeding, bathing. And then do you see item 6, progressive pressure ulcers since June 4th, 2017, is that right?
Correct.
Is it your understanding she was suffering from pressure ulcers when she was admitted to hospice?
No, I don't think she had pressure ulcers when she was admitted to hospice.
So she had them 4 days later, is that right?
That was not documented in the chart.
Well, reads current here. So what's that?
That was not documented in the chart that I reviewed.
The pressure ulcers.
Correct.
So you're saying she had pressure ulcers or she didn't have pressure ulcers?
I'm saying I don't know.
All right. And
Documented.
did you speak with anyone about your deposition testimony over the
Oh,
course?
okay, so then the answer is no.
Sir? Did you speak with anyone over the break about your deposition here today?
No. That's unethical.
Sir?
That's unethical.
Reads progressive stage 3 to 4 pressure ulcers in spite of optimal care. Do you see that?
Correct.
And that's again signed by Rachel McKnight here, right?
Well, she did not check that as being one of the problems. This is a format for deciding whether or not a person has meets criteria for hospice admission. And
Mhm.
so she did not mention or check that part of it.
But you testified before the break, though, that she had pressure ulcers, right?
No, I didn't say that. I said I didn't see that in the chart, so I don't know.
Are you also aware of the morphine warnings for prescribing? Well, we'll start with fentanyl. Fentanyl is an opioid, is that right?
Correct,
Morphine's an opioid, right?
correct,
Hydrocodone's an opioid.
correct.
And do you agree that benzodiazepines and opioids could share an enzyme in their elimination?
It can, yes.
And what that means, or why that could be problematic, is that it could, if a patient's given opioids and benzodiazepines and can eliminate those, then those can build up in your body as those drugs are administered, right?
Yes, they can.
Yes, ma'am. You testified earlier that Shirley Couch had pressure ulcers on the LCD and the plan of care. Will you show me in the plan of care where you were talking about before the break today?
So, okay. All right, just a minute here. Oh, I know what I did, okay? And
What'd
it
you
is
do?
my error. I saw that in the LCD policy, but it wasn't marked. So she did not have pressure ulcers.
Right. So when you testified to that, that was in error earlier. Is that right?
It's my faux pas, yes.
When you reviewed Dr. Shiver's deposition, you also reviewed the medical director job description that was attached to it.
Yes, sir, I did.
And it refers to, at the top of the first page, a primary physician, is that right?
That is correct.
And in this case, and for this hospice facility, Dr. Shiver was both the medical director and the primary physician, right?
That is correct.
The medical director is also required to be board eligible by the American Academy of Hospice and Palliative Medicine. Is that right?
No,
Have at least 2 years hospice experience?
no, that is in the conditions of participation. The only requirement for a medical director is that he be a licensed physician in his state.
Yes, sir. And we can talk about QTAM cases, False Claims Act cases, and the difference in conditions of participation and payment. But what I'm talking about right now is,
I'm talking about payment. I'm
Doctor-
talking about the qualifications for the attending physician and medical director under the conditions of participation. If you want me to, I'll read you the federal law.
I'm talking about Dr. Shiver.
Just, all it requires is a licensed physician. Period. That's it.
You recall seeing Dr. Shiver's agreement to become board certified? You remember that?
Yes, I saw that, sir.
We'll make this exhibit 2, Madam Court Reporter. These are things he agreed to do as a condition of his employment, right?
I guess he didn't.
The form, you can answer.
But, and you did, I believe you testified earlier, you didn't realize that you had, as a condition of participation for Medicare, Medicaid, you bill the government for your services, right?
Absolutely, sir.
And you, and that's for Medicare or Medicaid, depending on the patient, right?
Correct. And private insurance.
Sir?
And private insurance.
Right. And what percentage of your patient billing is private insurance versus government? Medicare, Medicaid.
15%. Most of it is Medicare and Medicaid.
I didn't mean to interrupt you. Go ahead.
I'm sorry?
15% is private pay, is that right?
Well, I would say 20% and 80% is Medicare and Medicaid. About 1%, 2% is Medicaid.
All right, 80% is Medicare and 1% Medicaid?
Correct.
And if Georgia law requires the medical director to have admitting privileges, and Dr. Shiver's only medical director, and he doesn't have admitting privileges, he's not able to submit bills for Medicare, Medicaid payments, for governmental payments, right?
Objection
Object
upon
form.
a legal conclusion.
No,
What's that?
he can bill, but when he sees the patient in his office,
Well, you have to meet the requirements to bill.
there's
Same
no
same
requirement
objection.
for hospital privileges for Medicare payment. If that's the question you're asking.
Well, actually, your testimony is that's not a requirement?
Not a requirement, no. The Medicare and Medicaid and government does not require board certification for billing for their services.
Yes, sir. We're not, and you went back to board certification from hospital privileges. Those are different, right?
No, that,
Yes, they are. You're saying
Yeah,
that
yeah, I agree with
the
you on
ability,
that.
don't interrupt me, the ability to
You
admit
did not have privileges
a
in the
hospital and have privileges with a hospital is the same as a board certification, sir? Is
No,
that your
it's not.
testimony?
Form.
And if you have an agreement, if you employ a medical director and the medical director is required to become board certified within 2 years, you expect him to comply with that portion of your agreement?
Objection calls for an incomplete hypothetical.
Man, so-
That's between the agreement and the doctor.
you
I
mean,
would assume that he would have to honor his agreement.
right. And what if the physician doesn't honor that agreement? He'd be in breach of that agreement, right?
Objective form.
Calls for legal conclusion.
You may answer.
No comment.
No comment. What do you mean, no comment?
That the physician and the hospice can negotiate. And the doctor would have to leave his practice and go to a facility or a university to become board certified in hospice and palliative medicine. I don't think that Dr. Shiver realized that. So there's no way that he could leave his practice for a year or two and then be certified and come back. The certification now for hospice physicians is a hospice medical director certification given by the American Board of Hospice and Palliative Medicine. And that makes you an expert in hospice and palliative medicine.
And your company is called what?
Palliative Medicine Consulting Services.
Right. And if your company, Palliative Medicine Consulting Services, employed a medical director, you would require that he comply with the law so that you could get paid for his work, right?
Applying to the law would be have to be a licensed physician in the state of Texas.
No, sir, I'm not. I'm talking about complying with the rules by the DM for Medicare and Medicaid payments.
Objection to form calls for a legal conclusion.
Medicare and Medicaid does not
Fine.
require board certification. It just requires you as a licensed physician, period.
Yeah. Well, what those requirements are, you will require that your physician that you employ comply with those, right?
Objection calls for
You
legal
require
conclusion.
a physician to be licensed, period.
And of course, a physician has to be licensed. If he's practicing medicine without a license, that's a crime in all 50 states, right?
Correct.
Just because a physician is licensed doesn't mean he gets paid by Medicare or Medicaid, right?
Objection calls for speculation.
Answer.
Repeat the question.
Could you read it back, please, ma'am?
Question, just because the physician is licensed doesn't mean he gets paid by Medicare or Medicaid, right?
I think we're on.
That he does or he doesn't get paid by Medicare.
You're saying just because a physician is licensed, there aren't other requirements that he would have to comply with to bill the federal government to care for a hospice patient?
Objection
Objective form.
calls for legal conclusion.
Answer.
Correct.
Correct what?
It is correct. All you needed to be a licensed physician to bill Medicare and Medicaid, period.
And there are no other requirements.
No,
And you have any opinions in this case that you haven't shared with me already here today?
Objective form.
Let me answer.
yes, I have an opinion
All right, what is it?
that Dr. Shiver did nothing wrong.
All right.
He
Anything
followed
else?
standards of care of hospice and palliative medicine.
Anything
He
else?
titrated the medication appropriately based on morphine equivalents.
Anything else? I think our time is up. Enjoy your day.
Now, I have a few questions, but I need to look at my notes for a minute. Can we take a 5-minute break?
Sure.
We're going off the record at 6:05 p.m. We're back on the record at 6:13 p.m.
Hello, doctor. Thank you so much for staying for this deposition. I appreciate your time.
Well, you're quite welcome, Felicia.
My name is Felicia LeRae. I represent all of the defendants with the exception of Dr. James Shiver and Renee Bonner in this case, okay?
Yes, ma'am.
So a minute ago, you were off the record talking about your background and expertise. I think that counsel for plaintiff interrupted you quite a few times when you were trying to give your background. Can you tell us about your background and what makes you an expert in palliative care?
Okay, so the short version, okay. I'm a Hispanic gentleman, okay, that got the privilege of going to the University of Texas in Austin Pharmacy School. I was in love with chemistry and medicinal chemistry. I practiced pharmacy for 8 years. And actually, if you want to look, my picture came out on Texas Pharmacy as one of the outstanding young pharmacists in the state of Texas. And then I got an opportunity to go to medical school. And I finished my medical school at New York Medical College in Valhalla. Great training in New York. And then I was around some wonderful people here in Dallas, UT Southwestern. So I worked with Dr. Selden, who had the outstanding school of internal medicine as far as the training was concerned. And then I mentioned Seymour Eisenberg, who was a protege to Tinsley Harrison, who wrote the textbook of internal medicine. I've been the privilege to know people that started hospice for the first time. I was first hospice medical director in 1985. So I've had 37 years of hospice experience. I've been involved in regulatory and compliance issues. I do medical legal consulting at the side, and I have interest in different things around my career. So pain management, non-pain symptom management. My last two things that I'm very proud of is I've done work and research on Alzheimer's disease, because my mom had Alzheimer's disease, and I'm an expert and a dementia coach in Alzheimer's disease. And I'm also, the last 5 years, spent time researching endocannabinoids, because there's a lot of CBD information out there, and delta H tetrahydrocannabinol. So I know how to use it, I know how it works, and I've done research in that area for caring for patients and guiding them on making sure they use the correct dosage and things of that sort. So, and I have not stopped really learning. I think that's more than anything, is learning about medicine and how we can improve people. My avocation is education and training, because that creates excellence.
Okay, and you've been practicing in the palliative care and hospice space for the last 3 or 5 years, right?
Well, ma'am, no, ma'am. I was the director of the first palliative care programs in the United States.
And
for
I
the
think
University of Texas Health Science Center. So when they developed a new specialty, I was part of the group that started the first 41 fellowship in palliative medicine in the United States. And the school happened to be an osteopathic school. So I was kind of like a fish out of water in an osteopathic school as an allopathic doctor. But they gave me the title of Deputy Director of Palliative Medicine. And my fellows were trained both at the NIH, also with a brilliant man, Russell Portnoy at Beth Israel, Albert Einstein School of Medicine. And my fellows were also trained with my colleagues at the UT Medical School, which is the MD Anderson. And I have friends from MD Anderson for years that I've learned both in cancer and pain management.
okay, and you have decades of experience in all those areas that you just listed, correct?
Absolutely, ma'am.
Okay. I'm going to show you what I'm going to mark as Defense Exhibit 1.
Mhm.
I'll share my screen. Can you tell me what you can see?
Yes, ma'am. These are all the diagnoses for Mrs. Couch.
Okay, and so earlier today, counsel for plaintiff was trying to elicit testimony that any one of these conditions in and of itself does not make you hospice eligible, correct?
Correct.
But the fact of the matter in this case is that Ms. Couch had a variety of medical conditions, true?
That is absolutely correct.
And she had a variety of comorbidities, correct?
Absolutely.
So for example, she was diagnosed with osteoarthritis,
Mhm.
correct?
Correct.
And she had essential hypertension,
Correct.
and she had a history of vertigo,
Correct.
and she had mixed hyperlipidemia,
Correct.
and she had other vitamin B12 deficiency anemia,
Correct.
and she had a CVA or cerebral vascular accident or disease,
Yeah, stroke. Correct.
and she had unspecified late effects of the cerebral vascular disease.
Correct. And she also had non-malignant pain of her joints.
Okay. And she had unspecified chest pain.
Correct.
She had acute sinusitis.
Correct.
She had unspecified visual loss,
Probably from a stroke.
and she had unspecified open wound of the head without complications from a fall.
That's correct.
And she needed prophylactic vaccinations, which is just for flu shot.
That is correct.
And she had chronic urinary tract infections
That's correct.
and debility from them.
Correct.
And she had dysphagia.
Yes, ma'am. Difficulty in swallowing.
Okay. And she also had peripheral vascular disease.
That's correct.
And she had chest pain.
Correct.
And she had incontinence.
That is right.
And she had gastroesophageal reflux disease.
Heard. Yes, that's correct.
And she had left hemiparesis.
Correct. Paralysis of the left arm. and side.
Okay. And earlier today, you were trying to provide an explanation of the difference between hemiparesis and hemiplegia. Is that
Correct.
right? I think counsel for plaintiff cut you off a few times. Do you want to have an opportunity to explain the difference now?
Hemiplegia is just a weakness. You can still move the arm. Hemiparesis, you cannot move that particular extremity.
Okay. And Ms. Couch had left hemiparesis, correct?
Correct?
As a result of her stroke.
Correct?
And it doesn't matter that the stroke was 8 or 9 years ago. It was just because she had it as a result of the stroke, true?
Absolutely, ma'am.
Okay. She also had atrial fibrillation and flutter,
Correct, which is a comorbidity for strokes.
and she had dysphagia as a late effect of the cerebral vascular disease.
Yes, ma'am.
She had end organ deafness.
Uh-huh.
She had hemiplegia of the non-dominant side as a late effect of cerebral vascular disease.
That's correct.
And she had a rash and chest wall tenderness.
That's correct.
She had contusions.
That is correct.
She had pain in her left arm. She had pain in her left arm
Yes,
and pain in her left knee
correct.
because she had severe osteoporosis, correct?
Yeah, but she also had post-stroke syndrome, which I mentioned in my note, from a stroke.
Okay. And she had deep vein thrombosis.
Yes, ma'am. Clots in her legs.
And she had long-term current use of anticoagulants, true?
She had coagulopathy and required anticoagulants.
And she had cerebral vascular disease, right?
Correct.
And she had deep vein thrombosis of her lower extremity.
Correct.
And she had pain in her limbs
Mhm.
and urinary symptoms,
Mhm.
correct?
Yes, ma'am. Correct.
And she had shoulder pain
Yes, ma'am.
and a variety of other conditions, including malaise and fatigue and vitamin D deficiency, correct?
Correct.
And this was from Dr. Parks, who had been treating her from 2013, true?
That is correct.
So it seems that Dr. Parks, her primary medical doctor, not Dr. Singh, who had just known her from the hospital visit, would have a better understanding of his patient's condition, true?
Absolutely.
Okay. And then I'm going to go down to the medications. Now, counsel for plaintiff likes to characterize his plaintiff as being opioid naive, but that's not true, correct?
That is not true.
Okay, and the records indicate that Ms. Couch received prescription pain medicine as early as 2013, true?
That's, well, actually, yes, absolutely.
And she had been prescribed Percocet, true?
Highly potent oxycodone. Yes, ma'am.
And oxycodone
She was
is an
never opiate naive.
okay. And Dr. Parks described that as a very strong pain medication, correct?
Correct. And he prescribed tramadol as well, which is also an opiate.
And that was in 2014, correct?
Correct.
And tramadol is a synthetic opioid pain medication, true?
Tramadol, no, it still works on the mu receptor, just like the other opiates. So a lot of people think that it's not, but it is an opiate.
Okay. And in July 2014, Ms. Couch was prescribed oxycodone, right?
That is correct.
And that's one of the strongest opioid pain medications that she consistently used for her left leg pain. Is that true?
Correct. So that and the Percocet, which is oxycodone.
And Ms. Couch's medical records from Oconee Medical, which is Dr. Parks, reflects this long and extensive history of chronic opioid use. True?
Absolutely.
Okay. I'm going to scroll down a little bit. Were you aware that on May 30th, 2017, Ms. Couch was seen by Dr. Parks and she was accompanied by her daughters in his office?
Yes, I saw that in the chart.
Okay. And in that note, in that visit, Dr. Parks noted that Ms. Couch was admitted to Piedmont Athens Regional Medical Center from 4/14/2017 to 4/18/2017 due to a TIA and UTI with Pseudomonas. Is that true?
Yes, ma'am.
And what is a TIA?
Yeah, transient ischemic attack, which is a minor stroke, but it is a stroke.
Mhm. And a UTI?
That's a urinary tract infection with the bacteria is Pseudomonas.
Is-
And one of the things that we know for sure is that UTIs precipitate TIAs and strokes, because you don't necessarily have to have a embolic phenomenon. You can have a mycotic phenomenon, which is a cluster of bacteria that can cause a stroke. So most people who have UTIs are prone to transient ischemic attacks.
Okay, and just so I can tie up this knot right here, even if a person has one of these conditions that in and of itself and alone, as counsel for plaintiff like to point out, did not make that person hospice eligible, all of these medical conditions combined would make that person hospice eligible, potentially. True?
Absolutely.
All right. We're going to go back down to page 14 of Defense Exhibit 1. And we were talking about Ms. Couch's May 30th, 2017 visit to her physician, who had been treating her since 2013 and had a good idea of his patient. Dr. Parks noted that Ms. Couch went to the Oaks for rehab for a while. True?
Correct.
And she was living with an older daughter now, correct?
That is correct. Yes, ma'am, because she couldn't care for herself.
Yep. And according to the note, there was a problem with the youngest daughter who had the power of attorney initially. True?
There was some family conflict there, ma'am.
It's a difficult family dynamic in this case, wouldn't you agree?
Yes, ma'am.
Yeah. So Ms. Couch's house had been sold by her youngest daughter while she had the power of attorney, according to this note.
Yes, ma'am.
And her older daughter had the power of attorney at the time of this note, correct?
Yes, ma'am.
Okay. Ms. Couch continued to have urinary incontinence, true?
Yes, ma'am.
And general debility.
Correct.
And she was tried on medications for overactive bladder, which caused problems with severe constipation.
Most of those patients, the medications cause that problem.
Mhm. And apparently Ms. Couch had an evaluation by ortho, true?
Correct.
But they determined that she was not a candidate for surgery,
Because of all of her comorbidities.
which would have included all the list of medical conditions that we discussed a moment ago,
Correct.
including the fact that she had recurrent falls and hematomas.
That is correct. That exacerbated her pain.
Would she have been a good rehab candidate for rehabilitation based on all of those comorbidities and extensive medical conditions that she had?
Probably not.
She wouldn't have been able to complete rehab, true?
No, ma'am.
Okay. And she had a history of DVT, as you testified earlier,
Mhm.
but she was no longer on blood thinners because she had recurrent falls.
Yes, ma'am.
And she had a significant history for hematoma in the past, which required a blood transfusion.
That is correct.
Is that somebody an orthopedic doctor would likely operate on?
They would not, ma'am.
Okay. And down here it says that Ms. Couch had left-sided hemiparesis with no change.
Mhm.
True?
Yes, ma'am.
And she had a history of TIA, but she could not take anticoagulants
That is correct.
for all of the reasons set forth above, including the blood thinner that she was on and that she had recurrent falls.
Mhm.
And she continued to have, as early as May 2017, history of ischemia with CVA
Correct.
and residual left hemiparesis and numbness.
That is correct.
According to this note, she had chronic dysphagia,
Yes.
which you explained or testified as difficulty swallowing.
Yes.
He noted again her history of
Can I
hemorrhagic.
just make a comment, ma'am?
Of course you can, doctor.
The thousands of patients that I've taken care of, eating is the most difficult thing we do as human beings. And when you have difficulty in swallowing, you have a major, major life-changing situation,
Okay. And why is that?
because you can't swallow well. It decreases your appetite, and swallowing is very complex. So if you had a stroke, that inhibits your ability to swallow correctly, so you aspirate. So you have chronic silent aspiration as well as aspiration causing pneumonias.
Mhm.
If
And
you-
And could this dysphagia or difficulty swallowing have led to the 12-pound weight loss that you testified about earlier?
Absolutely.
Which would also indicate that a person is probably getting to the point where they're eligible for hospice, true?
Yes,
Combined with all of her other medical conditions and extensive medical history, true?
absolutely.
Okay. And then on this visit, Dr. Parks continued to note that Ms. Couch had a mild carotid stenosis.
Mhm.
After her carotid duplex on 8/13, true?
Mhm.
She had a benign thyroid.
Yes,
She had coronary artery disease.
correct,
She had dyslipidemia.
correct,
She continued to have hearing loss.
correct.
She continued to have vitamin D deficiency
Yes,
and urinary incontinence
correct.
and gastroesophageal reflux disease,
Yes,
osteoarthritis of her knees,
that is correct, ma'am.
which contributed to her difficulty ambulating
And falls.
and falls. And she continued to have the history of the DVT ×3.
Yes, ma'am.
That's the deep vein thrombosis, correct?
Correct.
And then she had an additional extensive surgical history as well, true?
Very much extensive.
Including
Thyroid, appendectomy, hysterectomy, ovarian tumor, which, makes you suspicious that, you have DVTs because there's some type of procoagulant from some type of cancer. So that does not surprise me that you had DVTs.
Ms. Couch was not a healthy woman, true?
No, ma'am, she was not.
Okay. And down here, Dr. Parks on page 15 of Defense Exhibit 1,
Mhm.
Dr. Parks stated that Ms. Couch had a significant decline in her health in the last 30 days, true?
Correct.
And she had recurrent UTIs due to urinary incontinence and her inability to stand
Correct.
because of her past strokes
Correct.
and because of her severe osteoarthritis in her knees, correct?
Absolutely.
And she was at risk of having more CVAs, but she couldn't tolerate the anti-coags due to recurrent falls, true?
Put it at great risk. That is correct.
And the history of severe hematoma.
From her fall.
And
Yeah.
Dr. Parks, the man who had been treating her since 2013, opined that she was hospice appropriate, true?
That is correct. He referred her to hospice.
And he referred her to hospice on that day.
Yes, ma'am.
And so you don't have any criticisms of the nurse for following the doctor's orders, true?
No, absolutely not.
Okay.
She was not making any diagnosis that were not already documented on the chart.
Okay. I'm going to show you one other thing over here. I'll mark this as Defense Exhibit 2. I represent to you that this is the transcript of Dr. Ken Parks. Now, earlier today, Counsel for Plaintiff tried to play a little bit of word games and argue that Dr. Parks testified that Ms. Couch was not opioid naive. Do you remember that?
Correct.
And then this is the actual deposition testimony where I asked, with all the history of tramadol and oxycodone and Percocets, would you classify Ms. Couch as opioid naive patient? Do you see that there?
Correct.
And this is we're on page 87 of Dr. Ken Parks' deposition transcript,
Correct.
starting at line 20, going to line 23. And can you read right here, line 23, what Dr. Parks actually testified to?
She wasn't opioid naive.
She wasn't opioid naive. So contrary to what the plaintiff's attorney is saying today and trying to make you testify that she was, her own doctor said that she was not opioid naive, true?
That is correct, because she took opiates for a long time.
Okay. Thank you, doctor. I don't have any further questions today.
Thank you very much.
Dr. Peralta, I just have a point of clarification for you. Give you the benefit of showing you Dr. Shiver's deposition testimony. You were asked several questions about whether or not Dr. Shiver had privileges at a hospital while he was providing hospice services. And this is the actual excerpt from Dr. Shiver's deposition testimony. Do you see where I'm looking at on page 11, lines 6 through 12?
Sure, I'm gonna just see if I can increase the size of it.
Yeah, here, I can do it as well here.
Okay. All right, you're good.
Does it state here on line 6? All right, do you have privileges at Athens Regional Medical Center? Answer, I did. Question, you do. Answer, I did. I've dropped my privileges since I quit working for Homestead Hospice. Did I read that correctly?
That is correct.
Okay. I will stop sharing there, and I will show you the credentialing portion of. This is a letter dated April 27th, 2016, which granted Dr. Shiver credentialed Dr. Shiver for staff privileges at Athens Regional Medical Center from a time period of April 30th, 2016 to April 30th, 2018. Is that correct?
That is correct, yes.
Okay, and it was not until the resignation, which I am showing you on April 10th of 2018, that he no longer had privileges at Athens Regional Medical Center. Is that what this says here?
That is correct, yes.
Okay, thank you so much. So when you were asked questions about Dr. Shiver and whether or not he had credentials, you were not given the benefit of this information, were you?
No.
Okay, thank you so much. Those are all the questions I have.
I don't have any questions today. Thank you for your time, Dr. Peralta.
You're quite welcome.
I have some follow-up questions. I'll show you what's been marked as. Is it exhibit 3?
That's correct.
Thank you. Dr. Peralta, did
Yes, sir.
you read the orthopedist report in this case?
Orthopedic report.
Uh-huh.
No, I don't think I read an orthopedic report, but I
Did
did note that she was not eligible for any type of surgery because of her comorbidities. The orthopedic surgeon didn't feel she was a candidate.
But you're not an orthopedist, right?
No, no.
I want to mark as Exhibit 3, the Athens Bone Joint Orthopedic Clinic report dated March 20th, 2017. Patient demographics: Shirley Couch, female, white, English, dictation. Plan: I've suggested to her that we obtain cardiac evaluation before any surgical decisions are made. I referred her to Athens Regional Cardiology Group for evaluation to that end. I've asked her to be as active as she can be in the interim. She has bilateral hinged knee braces. You've not read that before today?
No, I wasn't aware of that report.
And this physician, this is John R. Doris, MD, and he is an orthopedic doctor.
Correct.
So he's giving her cardio clearance before the surgery.
Absolutely.
And she has the cardio clearance. So we're going to make this, what is this, Exhibit 4, Madam Court Reporter?
That's correct.
And this is from, and you haven't seen this either, you weren't provided with this?
Well,
Athens Cardio final report.
No, I don't know what you're talking about.
Did you ask to be provided with all the applicable documents in your case?
I
Okay,
assumed that I was.
Sir?
I didn't ask. I just assumed that they would send me information they wanted me to evaluate.
But you didn't get that orthopedist. That's just 3 months, March, April, May, June. That's just 3 months before she went into hospice, right?
Correct.
And the cardiologist examined her and came up with an assessment and plan. You hadn't read this either?
No, those,
Reads preoperative cardiovascular examination 201.810. That's a code, right, for billing?
I don't know. I'm not a cardiologist.
Although she is asymptomatic, she has very poor functional status. I've recommended additional ischemic evaluation with nuclear stress test and echocardiogram to better risk stratify her. If these are unremarkable or low risk, then she can proceed with planned surgery with acceptable cardiovascular risk. We will notify both the patient and Dr. Doris of our cardiac testing. You weren't provided with that?
That's not relevant to the clinical case here.
Oh, it is relevant if she was cleared for knee surgery 3 months before.
You're making an assumption if she was cleared.
Yes, sir.
That's an assumption.
Here, so you didn't see this either. Testing normal, okay to proceed.
Okay, well, that's an assumption. You
No,
don't know if
this is
normal or not.
this is what the physician has written in the note.
Well, that's right, but it's an assumption.
Testing normal, okay to proceed. That's an assumption.
Well, it depends on what kind of testing he did.
Well, I just told you what kind of testing you did. Can I read it to you again?
Echocardiogram?
I'm just gonna have a standing
Well,
objection
Michael,
to the fact that
yes.
the actual record's not being shown to the witness and portions of the record are being read without the benefit of actually showing it to the witness.
Yeah, well, I can email it to you. What's your email address? You can share it with him.
No, if you want to show it to him and pull it up and share your screen, feel free to ask him about it, but
My computer failed before the break. Do you remember that? I'm unable to do that.
no, I don't keep mental note of your technology issues. But if you would like to email it to me, I'm happy to email it to Dr. Peralta.
I'm sorry, I didn't catch that, James.
Exhibit 5.
Correct.
And this is the orthopedist. And I've suggested to her that we obtain cardiac evaluation before any surgical decisions are made. I've referred her to Athens Regional Cardiology Group for evaluation. To that end, I've asked her for her to be as active as she can be in the interim. She has bilateral hinged knee braces. You weren't provided with that either.
Same objection.
You may answer.
No,
All right. So she did get cardiac clearance and she did get clearance to have her knee surgery. You weren't aware of that?
No.
Object to form.
Yeah. Answer.
Join.
You weren't aware of that before today?
Same
No.
objection.
Objection to the extent it mischaracterizes evidence in the record.
You may answer.
no,
But that doesn't change any of your views, right?
no,
Were you told that she had not been cleared for knee surgery?
no.
Just doesn't matter to you, is that right?
But she had other comorbidities which would put her at risk. If she was my patient, I would not definitely recommend that she get knee surgery.
All right, but you're not an orthopedist or a cardiologist, right?
Yeah, well, an orthopedic surgeon thinks differently than an internal medicine and a palliative care doctor.
And you would defer to him, right?
I would challenge his opinion. And I get a second opinion.
Right, and opposing counsel also asked you about Dr. Parks. You remember that?
Correct?
And they read to you from his deposition. Do you remember that?
Yes,
They didn't read to you from his trial testimony. Is that right?
no,
Okay. That doesn't change what you testified to that about Shirley Couch's opioid use prior to June 1st and her status on June 1st, 2017, right?
no,
Object to form.
Is that right?
Same objection.
Join.
Testified truthfully early. Yeah,
she
Is
was
that
a
right?
doctor for hospice.
sir.
It doesn't, no, the answer is no.
What?
Changed my mind.
What? The answer is you testified truthfully earlier today.
Object to form.
You may answer.
Repeat the question. Okay,
Sure, you testified truthfully. Do you remember talking about Shirley Couch's Dr. Parks' testimony and her status as of June 1st, 2017?
correct. I read the document that of his referral to hospice. Yes,
Yeah, well, I mean, and you hadn't changed your testimony since that break, have you?
Object to form.
It's still the same, right?
Same objection.
We'll make this, what exhibit number is this, Madam Court Reporter?
If it's something new, it's number 6.
Number 6, this is Dr. Parks' trial testimony exhibits, pages numbered 103 and 104. This is number 7, is that right?
Pages 103 and 104 was exhibit 6.
And this is
Oh,
number 7. Number 7 is page 176 to Ken Park MD's deposition. At page 9, question, do you recall Dr. Singh sharing with you, this is Ken Park, being asked this question, her diagnosis of Shirley Couch's being in a medically induced coma, not on my apologies, not on the 30th, but on the 27th of June, 2017. Ms. LeRae, objection to form. Mr. Potts, you may answer. We had received medical records from the hospital which showed the diagnosis, Dr. Singh's records. Yes, sir. And you agreed with those. Dr. Parks answered yes. Have you seen that before today?
okay. You're asking two different questions. Okay.
No, so I'm asking, what have you
And
seen
one
that
from
before
Dr.
today?
Singh.
Sir?
You're asking two different questions. Okay. Okay. Dr. Singh's statement about her being in a medically induced coma is totally inaccurate. She was talking and she was complaining of hip pain during the time that she was being transported. That is not a patient in a medically induced opiate coma. It's absolutely incorrect in that statement.
You didn't read Dr. Park's deposition.
No. But Dr. Park wasn't there.
The question is, did you read his deposition?
I have the chart here of the EMT, picking her up.
That's objection, move to strike is non-responsive. Did you read his deposition?
No,
All right. And you said Dr. Park wasn't there. You weren't there either, were you?
no, but I have charts and information that says,
Were you there?
no,
No.
you weren't there either.
Now, you understand if someone's admitted to hospice, that's because you decide that they have 6 months or left to live, right?
That is correct, sir.
And that was in June 2017, is that right?
June the 1st, yes, sir.
And you testified about her in the past tense. You said she was a very sick woman, is that right?
Yes, that she was a very sick woman at that time.
Where is she still alive, right?
Yes, sir, I know that.
So let's see, 2017, that's 1 year. 2018, 2019, 2020, 2021, 2022, actually November 2022. And she's still very much alive. That's a lot longer than 6 months, isn't it, doctor?
That's correct, and that's not unusual.
It's not a, give me a cite for that. Cite any textbook, treatise, chapter.
Oh, yes, sir, but
Don't interrupt me.
But you're interrupting me.
Ways, anything like that, that it's not unusual for someone like Dr. Shiver to suggest a patient's only got 6 months to live, and 6 years later, she's still very much alive.
Objection.
Objective.
For me, any publication that says that's not unusual.
Same
Yes.
objection.
I can get those publications for you. They're published very well under the National Hospice and Palliative Care Organization as far as longevity. And then there's 2 doctors at Mount Sinai Hospital. They've done research on patients' extended length of stay.
All right.
If
And
you
what
want, I can send those articles to Ms. Barnes.
Oh, you don't know the states. This is, what exhibit number is this, Madam Court Reporter?
Number 8.
Dr. Ken Park's deposition, this is page 174. I would have answered that question. That's all I have.
I hate to do this to you, but I do have a follow-up question for you, Dr. Peralta.
Sure.
Do you need a break, or do you need?
No, I'm fine. I'm good.
Okay. I'm going to show you what I'm going to mark as Defense Exhibit 3. Can you see this document on my screen?
Yes, ma'am.
A moment ago, counsel for plaintiff was trying to understand the difference between cardiac clearance and clearance from an orthopedic surgeon. Do you remember that line of questioning?
Yes, ma'am.
And just because a patient gets cardio clearance from a cardiovascular doctor does not mean that they are necessarily a good surgical candidate. True?
Absolutely correct.
And this is Athens Regional Medical Center orthopedic consult note dated February 3rd, 2017 at 17:28 Eastern Standard Time, which is 5:28 p.m. True?
Mhm. That is correct.
And here she was seen by the orthopedic doctor, Dr. David Ryan. Do you see that?
Yes, ma'am.
And the orthopedic doctor, the one who would have had the ultimate say in whether she was a surgical candidate, opined that the plaintiff was not currently a candidate for knee replacement given her comorbidities, true?
That is correct.
And she was not a candidate for knee replacement given her pain control issues, right?
That's correct.
And she had nothing acute going on, true?
That is correct.
She was going to be followed up as an outpatient, true?
That is correct. Okay.
And the orthopedic doctor opined that he felt that orthopedics would have little to add to her care, true?
That is correct, ma'am.
And that's because she was an 81-year-old with multiple medical comorbidities, true?
Correct. At risk for strokes.
Including history of CVA affecting predominantly her left side.
Mhm.
And she was seen by his partner, Dr. Doris.
Okay.
That's true based on the records?
Correct.
In the past regarding her left knee, which has advanced to DJD, true?
Degenerative joint disease, correct.
And what exactly is that?
That's real deterioration of the joint, especially the knee or the hip, where
Mhm,
there is no cartilage and there's bone on bone type of situation.
mhm. So based on her medical records, Dr. David Ryan, who is the actual orthopedist,
Right?
opined that she was not a good surgical candidate, true?
True.
And if Mrs. Couch's orthopedics, Dr. David S. Ryan, who specializes in hip and knee replacement,
Right.
opines that Miss Couch was not a good surgical candidate, you would defer to the orthopedist, correct?
Absolutely. He's the one doing the surgery,
And
not the cardiologist.
Not the cardiovascular doctor who is simply providing clearance for the surgery itself, true?
That's correct. The burden is on the surgeon. And if he says the patient is not a candidate, that's the end of the story.
And in
Nothing
this,
else needs to be said.
okay, and just so that we're clear on the record, and in this case, this orthopedic surgeon made it abundantly clear that Miss Couch was not currently a candidate for knee replacement, notwithstanding what her cardiovascular doctor may have said.
That is absolutely correct.
Okay. Thank you so much for your time. I know this has been a long day and I appreciate your time and attention to this matter.
Yeah, you're quite welcome. It was a privilege and an honor to meet all of you. I think you all do a great job.
An additional question.
Thank you.
Well, February comes before March, is that right? Of
Excuse me?
course, February comes before March, right?
Okay,
And if she was cleared for surgery in March after her cardio clearance, then what does her not being cleared in February have to do with her surgery?
but she's not a candidate for surgery because the surgeon felt that it would be a great risk to her, regardless of whether the cardiologist cleared it or not.
They said she was a candidate.
Cardiologist just cleared her for cardiac problems. She was a person who had strokes and was on anticoagulant therapy. So, and she had falls. And candidly, the surgery itself would not help the patient itself by replacing a knee or a hip. She was too weak because of her stroke to really rehabilitate. I think the surgeon did the right thing, made the right decision, and with the best interest of the patient.
Well, but in March, he cleared her for surgery.
That is inconsequential.
Okay. It just doesn't change your view.
No,
Happened in the case.
no,
Nothing's going to change your view.
no, sir.
That's all I have.
He's gonna read and sign.
Yes.
And I would like an expedited E-tram, please. Oh, Bonnie,
You're muted.
That concludes the deposition of Dr. Peralta. We're going off the record at 6:59 PM.
Thank you very much.